Well, thank you, and I want to thank Priyanka and Jennifer for inviting me. Is this on? Yeah. Okay. So I'm going to try and look at the data, but I honestly don't think we're going to come up with a definite way of sequencing, but I'd be very interested in hearing the panel's discussion about this later on. So in the first-line setting, I think we know from the first-line trials shown here, these are the trials that look at the addition of CDK4/6 inhibitor to endocrine therapy in the first-line setting, palbociclib, ribociclib, and abemaciclib. We know that when you look at PFS, there's about a doubling of PFS in these trials, and it's pretty consistent, and the hazard ratios really are all ranging from 0.5 up to about kind of 0.6 or so across those trials. This is just including the MONALEESA-3 first-line patients. However, what was, I think, surprising to a lot of us was the overall survival data. So all of the MONALEESA trials that use ribociclib show an improvement, a significant improvement in overall survival. Monarch 3, which was just presented at San Antonio, doesn't show a significant improvement in overall survival, but looking at the delta here of 13 months, I think we'd all agree that it's clinically meaningful. The surprising thing here, of course, was the fact that the palbociclib trials didn't show an improvement in overall survival. Now, there are caveats that there was crossovers after the first-line setting, but nonetheless, I think taking that and some of the early-stage data we have, it does appear there is nuances between these different CDK4/6 inhibitors. So what about the question of, does everybody need a CDK4/6 inhibitor in the first-line setting? Well, I think it's worth discussing this trial, the SONIA study, because it is a large trial presented at ASCO, 1,000 patients from the Dutch group, pre- or postmenopausal patients, first-line hormone receptor-positive advanced breast cancer. They were randomized in the first-line setting to receive a non-steroidal aromatase inhibitor alone or with a CDK4/6 inhibitor. Oh, shoot. I didn't put that in. Can we go back? Oh, there we go. And then at progression, if they had not received a CDK4/6 inhibitor, they went on to receive fulvestrant plus a CDK4/6 inhibitor. If they had, they went on to receive fulvestrant. The primary endpoint here is PFS2, which is progression-free survival after 2 lines of treatment. So here's the progression-free survival 1. And I think I didn't show you the curves for the first-line studies, but this is really similar to what we've seen with the other randomized trials. The hazard ratio about 0.59, and it's about an 8-month improvement in PFS1. I don't know why it's doing this. Okay, so very consistent and significant. When you look at PFS2, however, what you see is the curves are very close together, and there actually isn't a significant difference in PFS2 in this study. However, you can see it's a 5-month, patients do 5 months better if they get a CDK4/6 inhibitor in the first-line study. So the point made from this was that given the added toxicity of the CDK4/6 inhibitors and the financial costs, that maybe we don't need to do it for every patient. And as we all know, we don't have a biomarker yet to tell us which patients don't need CDK4/6 inhibitors. However, I don't think this has really taken hold in the US. And the reason for that, I think, is this is MONALEESA-2. This is MONALEESA-2, which is the first-line study looking at the addition of ribociclib to letrozole. And I've circled here the median overall survival in the patients who got ribociclib plus letrozole. You can see it's more than 5 years. So this is the patients are living a median of more than 5 years by starting with ribociclib and an aromatase inhibitor, compared to the control arm where you can see it's 51 months. So I think unless there's really a good reason, most of us are going to go ahead and use a CDK4/6 inhibitor in the first-line setting. So I had to change this around a little bit, but we need to talk about genomic landscape of metastatic hormone receptor-positive breast cancer. Okay. So this was a study looking at a bunch of metastatic hormone receptor-positive specimens, and they looked at alterations in a number of key genes, some of which are therapeutically targetable. P53, obviously very common in all cancers, but also PIK3CA mutations in about 40% of hormone receptor-positive breast cancers. And importantly, these are present at diagnosis, so you can check for a PIK3CA mutation at any time during the patient's course. Perhaps more important, though, is the acquired mutations shown here. So we know ESR1 mutations probably occur in about 1/3 of patients throughout their hormone receptor-positive metastatic journey. Also, HER2 mutations I'll talk about briefly, but we have an expert in the room with Cynthia on that. And then AKT1 mutations, which now are important because of the approval of capivasertib. So when and how should we check? So I think, this has kind of changed a lot over the last 12 months or so, but I think most of us at some point will check genomics on the metastatic biopsy that we've done to basically determine that patients got metastatic disease. I think that we will do this earlier, and I'll show you why in a second. I don't know why it's doing this. This is not happening in my hotel room. Sorry, I don't know. So, but I think checking it once is not enough because of these acquired mutations. So I think it's important that at disease progression, pretty much every time we should keep checking ctDNA, looking for the acquired mutations, ESR1, ERB2, and AKT1. And I think this is what we use to kind of determine how we're going to partner up endocrine therapy with the agents that we have available. Now, the other reason for doing it earlier is because we now have this ANAVO 120 study, which is a very interesting study. Basically, this was patients first-line hormone receptor positive advanced breast cancer. They had to have PIK3CA mutated cancers, had to have measurable disease, and they also had to have progression during or within 12 months of completing adjuvant endocrine therapy. And they were randomized to a control arm of palbociclib plus fulvestrant and placebo, or to palbociclib fulvestrant plus ANAVO, which is a novel PI3 kinase inhibitor. And these results were just kind of a very, very late breaker at San Antonio, and you can see the curves separate very nicely in favor of the PI3 kinase inhibitor, 15 months versus 7.3 months. So it's about a doubling, in fact, more than a doubling, with a hazard ratio of 0.43 for using the PI3 kinase inhibitor. I think what's also notable here is how poorly the patients do in the control arm. The median progression-free survival is only 7. It's about half of what we would expect in that setting. And that could be because of the PIK3CA mutations, but also because they selected for patients that probably had endocrine-resistant disease. And the follow-up on this is 21 months. And here's the overall survival. It's not yet mature, but not reached in the ANAVO arm, and 31 months, as you can see in the control arm shown here. So we'll obviously follow that out. So I think obviously this isn't approved. The toxicity, of course, will be an issue here because we know that these agents are hard to give. But I think also we need to know, is it better to give them all together or should we sequence them? And we just don't have that information right now. So I'm going to spend the rest of the talk talking about what we do in the second line setting. And I've kind of touched on this already, but I think just broadly thinking about, does the patient have a tumor with an actionable mutation or not? If they don't, we'll talk about mTOR inhibition, switching your CDK4/6 inhibitor. If the actionable mutation, we kind of base how we treat our patients based on what type of mutation they have or what's the driver mutation. And of course, we do have the option always of using standard chemotherapy, although we use that less and less, and increasingly the antibody drug conjugates that Dr. Kalinsky will cover later on today. So these are the 3 post-progression CDK4/6 inhibitor trials. They work so well in the first-line setting, why not look at them in the second-line setting? So we'll go through these in a little bit more detail, but Maintain was really a switch from palbo to ribociclib, whereas PACE and Palmyra were really a continuation of palbociclib. And as you'll see when I show you the results, that probably explains some of the differences we see in the results. Okay. So Maintain, Kevin was the PI on this study. This was patients who'd had disease progression on endocrine therapy and any CDK4/6 inhibitor. They were allowed to have up to 1 chemotherapy for metastatic breast cancer. Importantly, in this study, 85% of patients received palbociclib in the first-line setting, which was kind of the standard of care at the time. They got randomized to receive endocrine therapy either with fulvestrant or exemestane, with placebo, or with ribociclib. And here's progression-free survival shown here. So you can see the curves certainly separate in favor of ribociclib. It is an endocrine refractory group of patients because the control arm, as you can see, is less than 3 months, up to 5 months when you switch essentially to ribociclib. Looking at the PACE study, a fairly similar design, progression as CDK4/6 inhibitor and endocrine therapy. We're allowed to have up to 2 lines of endocrine therapy and up to 1 line of chemotherapy. Randomized to single-agent fulvestrant, fulvestrant plus palbociclib, or fulvestrant palbociclib plus avelumab, the checkpoint inhibitor. Again, across these arms, 85 to 95% of patients receive palbociclib in the first-line setting. So this is really a continuation of palbociclib through progression. And here's the results shown here. If you just focus on the red and blue, which are the fulvestrant and fulvestrant palbociclib, there is no difference. The median progression-free survival is about 4.5 to 5 months in both those arms. Intriguingly, though, the avelumab arm, as you can see, has a progression-free survival of 8 months, with the suggestion there's a tail on here. So there is other ongoing trials looking at immune checkpoint inhibitors in hormone receptor positive metastatic breast cancer. And there also is some data suggesting that CDK4/6 inhibitors actually make cancers more immunologic and more sensitive to immune agents. And then Palmyra that was presented at ASCO. In this case, all patients had palbociclib in the first-line setting and had to have disease progression. They were randomized to receive endocrine therapy, either fulvestrant or letrozole, depending on what they got in the first-line setting, alone or with palbociclib. And again, this was negative. You can see here the curves kind of separate a little bit, but then come together. So 3.5 months versus 5 months on this trial. So taking all of these together, I think in selected patients, you could consider switching the CDK4/6 inhibitor, but continuing the CDK4/6 inhibitor really doesn't work. And this is important, of course, because we're now using CDK4/6 inhibitors in the adjuvant setting. And post-Monarch, very interesting trial. It's, again, slightly larger than the randomized phase 2 trials I just showed you. Hormone receptor positive, HER2 negative breast cancer have to have disease progression on a CDK4/6 inhibitor plus an aromatase inhibitor in the metastatic setting, or, and this is important, in the adjuvant setting, disease recurrence on or after a CDK4/6 inhibitor plus endocrine therapy. So this is an important question. And patients get randomized to fulvestrant plus placebo or fulvestrant plus abemaciclib. And this will be, I think, reported out this year from what we've heard. So obviously this will be important. It would be good to see these results. Now, moving on to the more endocrine refractory setting. So what we've known for a long time is that as cancers develop resistance to endocrine therapy, you get increased signaling through these upstream growth factors, including HER2, EGFR, VEGF. And we've done a bunch of trials looking at actually blocking these receptors individually. It doesn't work. However, what we do know is that if you actually focus on the downstream pathway, so the PI3 kinase AKT mTOR pathway, that's actually an effective way of treating hormone receptor positive breast cancers. So mTOR inhibitors, what we think, when there's endocrine resistance, there's phosphorylation through these pathways, which then alters the estrogen receptor so that endocrine therapy doesn't work anymore. So if you block this pathway, you can resensitize these cancers to endocrine therapy. So I always say, don't forget about everolimus, because when you look at these results, they're really kind of impressive, actually. So TAMRAD was the first study that came out. It was a randomized phase 2, patients with endocrine refractory metastatic breast cancer, randomized to receive tamoxifen or tamoxifen plus everolimus. You can see here there's a doubling in progression-free survival from 4.5 months up to almost 9 months, which was statistically significant. And then right after this, we had Bolero-2, which was the registration study, where patients were randomized to receive exemestane plus everolimus or exemestane plus placebo. Look at how separated these curves are, with a hazard ratio of 0.36 and highly statistically significant, and a 6-month difference in favor of using everolimus. So don't forget about this, because we know how to give this drug. It's pretty easy to tolerate, and I think that in patients that really have endocrine refractory disease, this really is a good agent to use. So now let's move to patients who have genomically driven cancers, or where we've worked out a mutation that's essentially driving the cancer. So SOLAR-1, I think you're all familiar with. This was pre-treated hormone receptor positive metastatic breast cancer. They had to have tissue available for PIK3CA analysis, and there was 2 cohorts, a PIK3CA mutant cohort and a PIK3CA non-mutant cohort. In both cases, they got randomized to fulvestrant plus placebo or fulvestrant plus the PI3 kinase inhibitor alpelisib. The primary endpoint was PFS in the PIK3CA mutant cohort. And just as history to this, we actually had a number of phase 3 trials looking at different PI3 kinase inhibitors prior to this study that were very toxic, very modest activity, and PIK3CA mutations were not found to be a biomarker. So this is why this trial was so important. And here's the results shown here. So you can see, again, the curves separate pretty early in favor of the PI3 kinase inhibitor, 6 months versus 11 months. So this is really pretty impressive in the endocrine refractory setting. And this is in patients whose tumors have PIK3CA mutations. The survival was looked at later on as well, and you can see the curves do separate, but it actually wasn't statistically significant when you look at overall survival. Obviously, it's a tough drug to give, but I do think, and there are other PI3 kinase inhibitors that are in development right now, but these results certainly would convince you that for efficacy reasons, this should be considered. Now, only a small percentage of patients in SOLAR-1 had received a prior CDK4/6 inhibitor. So BYLieve was designed specifically to look at the efficacy of alpelisib in patients who had a prior CDK4/6 inhibitor. I'm just going to have you focus on cohort A because that's where the data is from. So these are patients who'd received a CDK4/6 inhibitor plus an aromatase inhibitor as immediate prior therapy, and they got treated with alpelisib plus fulvestrant. The primary endpoint was the proportion of patients with disease control at 6 months. And here's the results shown here. So it met its primary endpoint. 50% of patients were alive without disease progression at 6 months. The median PFS was 7.3, so a little bit lower than what we saw in SOLAR-1, but obviously we can't compare across trials. But I think this indicates that this is an effective approach. And now our new one on the block, our AKT inhibitor, capivasertib. So CAPItello-291, again, was hormone receptor positive pre-treated metastatic breast cancer. You can see the entry criteria there. They were allowed to have up to 2 lines of prior endocrine therapy, up to a line of chemotherapy. And they needed 50% of patients to have received a prior CDK4/6 inhibitor. Patients are randomized to receive fulvestrant plus placebo or fulvestrant plus capivasertib. And the primary endpoints were PFS in the overall population and then in the AKT pathway altered tumors. So what did that mean? Sorry, this is probably a little bit hard to see, but what they found was about 40% of patients had alterations in their AKT pathway. 60% either they couldn't find them or they weren't present. The majority of them, as you would expect, were PIK3CA mutations, as you can see shown here. And that was either alone or with other mutations. But you can see here 5% of patients had AKT1. Why is that important? Because it's an acquired mutation, and 5% had PTEN only. So again, this is important just to keep in mind. And here's the results again. Positive study. In the control arm, progression-free survival was 4 months, up to 7 months in the capivasertib arm, and that's in the overall population. Looking at patients whose tumors had that AKT pathway alteration, very similar results, 3 months up to 7 months, as you can see shown here. And then some exploratory analysis. On the left-hand part of the slide is basically patients, this was all patients, including the non-altered population. Again, no difference really from the primary results. And then overall survival, as you can see shown over here, the curves are kind of splitting in favor of the capivasertib, as you can see shown here. Overall, I must say I have not used this drug yet, but it does appear from the trial that it might have a slightly better toxicity profile to alpelisib, with less hyperglycemia, but obviously we'll wait and see what that looks like. And the question really is, can you use one before the other? And we just don't know those answers yet. And just to talk about the oral SERDs, so these are the ones that are in development. You can see they're all in phase 2, phase 3. Some of them are even in the early stage setting. I'm just going to focus on elacestrant just for the interest of time because that's the one that's approved right now. And the EMERALD study, I think you're all very familiar with. Again, hormone receptor positive metastatic breast cancer, pre-treated. So this was a fairly heavily pre-treated group of patients who'd received endocrine therapy. All of them had received a CDK4/6 inhibitor, and they were allowed to have received up to 1 line of chemotherapy. They were randomized to elacestrant on its own or investigators' choice of single-agent endocrine therapy, which could be fulvestrant, anastrozole, letrozole, or exemestane. There were 2 primary endpoints, progression-free survival in all patients and progression-free survival in patients whose tumors had ESR1 mutations. So here's the primary endpoint of PFS and the overall population. And you can see the curves clearly separate in favor of elacestrant. We'd say it's a fairly modest benefit. This is clearly very endocrine refractory tumors with only, in the standard of care arm, only 2 months progression-free survival and just maybe a little bit higher with the elacestrant. However, when you look at patients whose tumors had ESR1 mutation, it's a little bit more impressive. Really no difference in the standard of care arm, which you'd kind of expect. But you can see now at elacestrant, the PFS now is 4 months. And this is why the FDA approved this drug specifically for patients whose tumors have ESR1 mutations. And we got this data at San Antonio last year. It's quite interesting. What they did here was it was an unplanned subset analysis where they looked back to see how long patients have been on the CDK4/6 inhibitor before entering EMERALD. And what this basically shows is that the longer a patient was on a CDK4/6 inhibitor and endocrine therapy, in the first line or before they entered the trial, the more benefit they got from elacestrant. And so what you can see that if they got at least 6 months, the curves are fairly close, not different from the primary analysis, but you can see there's clearly more benefit with 8 months once you get to at least 12 months of using a CDK4/6 inhibitor with endocrine therapy. So I think this may be a marker of endocrine sensitivity because obviously elacestrant is an endocrine agent. And I think I didn't go through the other SERD trials just in the interest of time, but they all show pretty modest improvements in the overall population, but a signal in patients whose tumors have ESR1 mutations. And then lastly, just to talk about HER2 mutations. So these are pretty rare, but they are described in hormone receptor positive metastatic breast cancer, particularly lobular breast cancer, actually. So you can see in this analysis, and I don't know if this was yours, Cynthia, or not, I don't remember, but what they found was HER2 mutations in about 7% of cancers, but very important, they were almost all acquired, 83% were acquired. So again, this is something worth looking at. And the group at WashU, including Cynthia, had a lot of preclinical data showing that neratinib appeared to be particularly effective preclinically in cell lines that had HER2 mutations. So they did an analysis of that definitely showed activity, and this was followed by the SUMMIT study. So the SUMMIT study is a study that's looking at HER2 mutated cancers across a number of different solid tumors. This is a publication specifically on hormone receptor positive HER2 negative metastatic breast cancer. All of them had ERB2 mutations. And what happened here was they were initially treated with either fulvestrant plus trastuzumab or fulvestrant alone. And then at disease progression, they crossed over and neratinib was added into the mix. So if you look at the fulvestrant plus trastuzumab, there was really no responders. The PFS was about 4 months. But when they crossed over to neratinib, what you see then is that there was a response, it's a very small number of patients, and some clinical benefit and a better PFS. And the patients who just received fulvestrant initially, again, no responses, but at crossover, you can see there was 2 partial responses, 83% clinical benefit, and a PFS of 9.5. So again, this is interesting data. I think it requires validation, but I think this is another, neratinib is another agent that you can think about for our patients. So here's the NCCN guidelines following first-line progression, because I think we've kind of all decided to use the CDK4/6 inhibitor in the first-line setting. And they kind of break it out whether patients have, based on their volume of disease. So if they have high volume disease, they recommend using chemotherapy. If they don't, then go down the channel that I just talked about. And I came up, I apologize, this is a bit kind of rudimentary, but I came up with this last night on the plane. So I think, first-line endocrine therapy plus a CDK4/6 inhibitor. Navo, we'll see where that goes, okay? So it's not approved yet. I think checking genomics at the beginning makes sense because not only could it make a patient eligible for a Navo if that drug becomes approved, but also it allows you to kind of decide what you're going to do next for a patient. So the next decision point, and again, I do think checking ctDNA progression makes sense, is whether there's an actionable mutation or not. If there is, you're going to follow along. PI3 kinase mutation, we now have a choice, either alpelisib or capivasertib. Again, as I mentioned, I presume you can go from one to the other, but we just don't know. AKT1, P10 alteration, capivasertib, ESR1 mutation, elacestrant. And I think based on the data from the EMERALD study, might want to use this a little earlier, because I think once you develop endocrine refractory disease, this drug is not really going to work. So we can talk about if people have both mutations or several mutations, what we would do. And then for no actionable mutations, I still like everolimus a lot. I think switching the CDK4/6 inhibitor with endocrine therapy is an option, particularly in somebody who's been on a CDK4/6 inhibitor for a long time. Always keeping chemotherapy, capecitabine, I think we use it a lot. And as we'll hear about from Kevin later on, the antibody drug conjugates. And I put the arrow going both ways here because I think that you can go from your targeted therapy to essentially chemotherapy, but then maybe you check ctDNA and they have an ESR1 mutation, then maybe you can go back to these agents. So just to summarize, so I think, as I've said multiple times, the standard first line is endocrine therapy plus a CDK4/6 inhibitor. After that, we should make our decisions on genomic analysis of the tumor or increasingly ctDNA, and I talked about the different drugs that we have. I do think the sequencing may be impacted as the antibody drug conjugates move up in the treatment plan, and as I mentioned, we'll wait Kevin's assessment of that. So thank you very much for your attention.
Thank you, Dr. O'Regan, for this very nice summary and review and some take-home points for us. So we will now move on to our first case discussion session. So if you could take a seat there, and I'd like to invite our faculty from the morning to join us, Dr. Ma,